Welcome to the Explainer. So imagine a cancer where literally just one specific, abnormal cell dictates the entire course of the disease. It's a lymphoma that spreads with such predictable, orderly precision, we can basically track it like a roadmap. Combine that with incredibly high cure rates and some of the most classic, easily recognizable diagnostic clues in all of medicine, and well, you've got Hodgkin lymphoma. If you're prepping for your medical exams, whether that's NEAT PG, INIC, or your board exams, you absolutely cannot afford to miss these high-yield patterns. So today, we're going to master them.
Okay, let's dive into this roadmap. We are going to be looking at 1. The Reed-Sternberg cell. 2. Hodgkin versus non-Hodgkin. 3. Subtypes and CD markers. 4. Symptoms and Ann Arbor staging. 5. Diagnosis and ABVD treatment. And finally, 6. Rapid high-yield revision. This explainer is basically your ultra-efficient blueprint for exam success. Let's get to it.
Section 1. The Reed-Sternberg cell, the master manipulator.
Let's talk about the sheer visual distinctiveness of this B-cell malignancy. The Reed-Sternberg, or RS cell, is the absolute hallmark, the villain of our story really, for Hodgkin lymphoma. It's notoriously large and typically binucleate, meaning it has two distinct nuclei that kind of look right back at you, giving it that classic owl's eye appearance. You're going to see this described on exams time and time again. But here's a critical clinical pearl. Simply spotting an owl's eye cell isn't quite enough. For a definitive diagnosis, you actually have to find these RS cells sitting within the appropriate inflammatory background.
To understand why that background matters so much, we got to look at the pathophysiology. Step 1. The disease originates in germinal center B cells. Step 2. These malignant RS cells begin secreting just a massive storm of cytokines. And step 3, those cytokines attract normal, healthy inflammatory cells straight to the lymph node. Now, this is a huge exam insight, so pay attention. When a patient comes in with a swollen lymph node or systemic symptoms, that tumor bulk is actually driven primarily by the recruited reactive inflammatory cells, not just the malignant RS cells themselves. The RS cell is essentially throwing this chaotic party and inviting all the normal cells to bulk up the node. Crazy, right?
Section 2. Hodgkin versus non-Hodgkin, the crucial distinctions.
Understanding this contrast is exactly how you're going to rule out other lymphomas on those tricky multiple-choice questions. And this brilliantly illustrates the core differences. Notice the spread. Hodgkin lymphoma has a contiguous spread. That means it moves neatly, orderly, from one lymph node group directly to the next adjacent group. If you see orderly spread, you immediately think Hodgkin. Non-Hodgkin, on the flip side, is non-contiguous and super erratic. Plus, extranodal involvement is rare in Hodgkin, but it's really common in non-Hodgkin. Naturally, the RS cells are present in Hodgkin and absent in non-Hodgkin. Oh, and finally, keep a close eye on the patient's age. Hodgkin lymphoma classically presents with a bimodal age distribution, whereas non-Hodgkin, well, it can strike at practically any age.
Section 3. Subtypes and CD markers, categorizing the disease. So Hodgkin lymphoma is divided into two main categories. The vast majority, like 95%, is classical Hodgkin lymphoma. Within this classical group, nodular sclerosis is by far the most common subtype you're going to encounter. We also have mixed cellularity, which is super testable because of its strong association with the Epstein-Barr virus, or EBV. Then there are the lymphocyte-rich and lymphocyte-depleted subtypes. It's also really vital to remember that an HIV infection increases the overall risk for developing these. Now, outside of that classical 95%, we have the rare nodular lymphocyte-predominant Hodgkin lymphoma, or NLPHL for short. Instead of those classic owl's eyes, NLPHL features variant RS cells that are commonly referred to as popcorn cells.
So the crucial point here is how you definitively identify these on a molecular level. This is an absolute must-know exam pearl. Classical Hodgkin lymphoma will stain positive for CD15 and CD30. On the flip side, the variant NLPHL subtype will stain positive for CD20. Lock those numbers into your brain. CD15 and 30 for classical, CD20 for those popcorn cells of NLPHL.
Section 4. Symptoms and Ann Arbor staging, clinical presentation. Let's talk about what this actually looks like in a patient. The core clinical presentation usually starts with painless cervical lymphadenopathy, so a swollen, non-tender lymph node right in the neck. Then we look for the famous B symptoms. These are fever, drenching night sweats, and unintentional weight loss. Remember, these systemic symptoms are largely driven by that cytokine storm we talked about earlier. And here's a highly specific, classic clue that examiners absolutely love to throw at you: alcohol-induced lymph node pain. It's relatively rare in the real world, honestly, but if a test question mentions a patient whose swollen lymph node aches after having a glass of wine, boom, you are looking at Hodgkin lymphoma.
Once we suspect it, we use the Ann Arbor staging system to track its linear, contiguous progression. Stage I means the disease is confined to just a single lymph node region. Stage 2 involves 2 or more nodal regions, but they are entirely on the same side of the diaphragm, so either all above it or all below it. Stage 3 is when the disease crosses that line, involving lymph nodes on both sides of the diaphragm. And finally, Stage 4 indicates disseminated extranodal involvement, meaning it's spreading to organs like the liver or bone marrow. As a quick modifier, we add A if the patient has no B symptoms, and B if those fever, night sweats, and weight loss symptoms are actually present.
Section 5. Diagnosis and ABVD treatment, managing the disease.
Now, to actually get that diagnosis, you need the gold standard, an excisional lymph node biopsy. You have to take the whole node out to really evaluate the architecture and find those Reed-Sternberg cells hiding within their reactive inflammatory background. Please, whatever you do not fall for the classic exam trap here. Fine needle aspiration cytology, or FNAC, is not diagnostic for Hodgkin lymphoma. It simply doesn't provide enough tissue architecture to confirm the diagnosis safely. You absolutely must excise.
Once it's confirmed, the prognosis is actually generally excellent, way better than most non-Hodgkin lymphomas, though of course it depends on the patient's stage, age, and whether those B symptoms are present. The standard treatment arsenal is the ABVD regimen. This stands for adriamycin, which you might know as doxorubicin, bleomycin, vinblastine, and dacarbazine. This specific combination is highly effective and absolutely represents the standard of care.
However, as we all know, these drugs come with some serious baggage, and examiners want to make sure you know exactly what to watch out for. The most testable toxicity in this entire regimen belongs to bleomycin. Bleomycin is famously associated with causing pulmonary fibrosis. So if you have a patient being treated for Hodgkin lymphoma who suddenly develops a dry cough and shortness of breath, pulmonary fibrosis from bleomycin should be your immediate suspect.
Section 6. Rapid high-yield revision, final exam polish.
All right, let's pull all of this together and see how it builds into an unstoppable diagnostic framework for you. Remember these top one-liners. The Reed-Sternberg cell is the absolute hallmark. For classical Hodgkin lymphoma, you're looking for CD15 and CD30 positivity. If a patient experiences lymph node pain right after drinking, that's your classic alcohol pain clue. The most common subtype? Nodular sclerosis. The gold standard treatment? The ABVD regimen. And the disease spreads in a very orderly, contiguous manner.
Hodgkin lymphoma is honestly one of the most predictable and testable malignancies in all of medicine. You now have the complete blueprint to tackle it. So let me leave you with this final thought. If you're presented with a clinical vignette featuring an owl's eye cell, an orderly contiguous spread, and positive CD15 and CD30 markers, what's your diagnosis and how quickly are you going to ace that question? Thanks for joining me for this explainer, and keep that focused learning going.